Knee cartilage injuries can happen randomly, so from somebody starting to have problems over months to years. Most of the cartilage injuries that we deal with are in the knee. There's some in the elbow, some in the shoulder, and some in the hip, but most of the stuff that we deal with is in the knee because that's where most of the treatments are. So imagine a chicken bone. They've got the two condyles of the chicken bone, they're usually white. And so when the cartilage is damaged, that whiteness goes away. It can be anywhere from a large defect to a small defect, but basically that cartilage goes away and it becomes painful because the bone becomes exposed. And this can set off a cascade of other issues. But mainly it's that white cartilage that becomes missing and the pain receptors increase, and then you have other changes that go on. Knee cartilage injuries can happen randomly, so from somebody starting to have problems over months to years. They can happen from an acute injury, such as they twisted their knee or dislocated a part of their knee and then injured the cartilage from that event. And some people can get it from a direct injury or direct blow to the cartilage as well. So there are a number of different ways that can happen. Not all cartilage injuries are symptomatic, but when they're symptomatic, those are usually the patients that I see because they actually have discomfort. When they're discomfort, they're actually usually quite vague, the symptoms. And that's what's important to understand for patients because, you won't come in and say, my knee feels like I tore something. You'll come in and say, my knee aches. And it could be globally, especially if it's deeper in the knee. But the number one symptom is swelling. And that's what I get most worried about. So when a young patient comes in and they have swelling or maybe a mild locking, usually in my practice, swelling with a younger patient is a cartilage injury until proven otherwise. So patients should consider coming in for a cartilage injury based off of their symptoms and how they're doing. It depends on each patient's threshold. We see patients that initially present to me with minimal symptoms and eventually they develop more and need something done, or they are found to have a cartilage injury. I would tell most patients if their knee is swelling for more than 4 to 6 weeks, they should probably be evaluated by an orthopedic surgeon. If they have pain and they're not able to do their activities, which is really my threshold, if you are not happy with the current state of your knee and it swells and it's painful and it's been 4 to 6 weeks, I would strongly recommend you see somebody because there are a lot of times when that is usually an issue, and usually things will self-resolve earlier than that. But it's completely okay if you injure yourself and have a large swelling and you're in pain within 2 to 3 days to come see me in my office too. But I less worry about those patients because they come to see me sooner. I'm more worried about the patients that let their knee linger. So when patients come to my office and there's a concern for a cartilage injury or they come in with swelling, pain, or locking, usually the first thing we do is have a conversation. I want to get more background, because a lot of times these patients have had other surgeries before, and then this ends up happening. So cartilage is usually the last thing to go. If you have meniscus or an ACL injury, those things tend to happen first, and those are treated. Less people are comfortable with cartilage, so the cartilage ends up being sort of the afterthought for some people. And so usually they come in, they've got swelling, they're still in pain, and that's usually when they come to see me for treatment. When they come in, after we get a full history and story from them, we'll do a physical exam. What I'm looking for in the exam is not only the problem, but what's causing the problem. So, do patients have a loose ACL that's also causing the cartilage injury? Do patients have missing meniscus or missing things that are causing this cartilage injury, or is this injury just in isolation? And so I'm doing examination of their kneecap to make sure it's stable. I'm doing their knee to make sure it's stable. I'm checking all their ligaments out to make sure they're stable. If all those things check out, but they still are having this problem, then I'm trying to figure out, is this an isolated injury? And then once I have that information, if I'm at all concerned, generally someone who's younger, who's had continued problems and pain and swelling, we check obviously an x-ray to make sure there's not a lot of arthritis, means that the joints are not narrowing and they've lost cartilage. That x-ray usually is negative in younger patients because before the arthritis starts, they may have a small injury to their cartilage and that has not taken progress in terms of the arthritis. If all of those things check out, the next thing we consider is an MRI. And that's sort of the first step of our preliminary evaluation. One thing that comes in my office a lot is people are wondering why I didn't identify these things on x-ray. But the x-ray is usually for just evaluating the bones. So if someone has a broken bone or a piece of bone broken, etc., they will be identified on the x-ray or alignment issues. Most patients, at least in my office, because I tend to have younger, more athletic patients, these x-rays are negative. But they're a necessary need to confirm there's nothing larger going on. And then if we get an MRI, which is usually the next step, this will let me look at the soft tissue. So that's the part that's not visible on x-ray. If you were to look at an x-ray, it would look clear. And there's nothing there. But really there is stuff there. That's what's holding the joints open. That's why they don't look narrowed like you have arthritis. And so what we're looking for is the meniscus. We're looking at all the ligaments of the knee, the ACL, the PCL, the MCL, and the LCL. And then we're looking at the cartilage. And there's different types of MRIs that I can do. But in general, we do these basic MRIs to evaluate all of those things and see if there's anything else we need to look into further. The first thing when you come into my office with a cartilage injury is we always consider non-operative treatments. And I usually ask my patients this and give them the options. Once we've identified a cartilage injury on MRI, so usually we don't jump into any type of treatment until that MRI is confirming that there's a problem. Once we've confirmed there's a problem, it depends on the size of the defect and how much pain the patient's having. But again, as I mentioned in my philosophy, it's always the patient's decision. So I like to give multiple options. Sometimes my patients don't like it because they want me to make a decision for them. But my whole goal is to force the patients to make a decision that works best for them because I've got this gamut of options. The main option I always start with is non-operative treatment, physical therapy, rest, ice, etc. Sometimes they've come in, they've taken care of all those things, so they don't want to go with that step, but sometimes that step works for people. The next option is to consider injection options. So injection options can anywhere from cortisone, which I tend to do less of in younger patients because I do not want to cause long-term damage to the cartilage. One injection is not going to cause a lot of problems, but people have different opinions on that, and so I tend not to do as many of those, but that is an option. The other option is something called PRP, which is biologics, and that's a potent anti-inflammatory that we can give patients, and that is a really good option for cartilage patients or patients who have sort of lack of cartilage in that area, and that may help their symptoms. Again, these are options that they're given as all elective options for them to choose from. If they've tried those options, or they're frustrated and they're coming to me directly for a surgical procedure, which happens frequently, then we start talking about what options we have to correct this. I don't want to go into too much detail on how we treat different cartilage procedures, but we'll be basic as much as we can be basic. Generally, smaller defects, less than a centimeter, are asymptomatic. But again, the MRI is not always perfect. So just because we get an MRI, you just heard all this information about how it's so important for us to get an MRI. The MRI only gives me a signal. It says, look here, this is a problem, but it doesn't always tell the extent of it. If we're concerned enough about it and you've failed all those other treatment options, or you don't want to have some of those treatment options because you're tired of it, let's say you've come in with 2 or 3 years of pain, it's completely understandable. The next option with many of my cartilage procedures is to do a diagnostic arthroscopy. So what we do is we put 2 poke holes in the knee with a small scope. We not only evaluate the cartilage, but we will clean it, and sometimes alone that is effective. At the same time, if they're a candidate for some of the procedures we will talk about very briefly, we may be able to take a small biopsy of their cartilage that we can use later on if a cartilage procedure is needed. Once that is done, usually I talk to my patients a day or 2 after the surgery once anesthesia is worn off, and we have a conversation as to what we found. Sometimes the decision is, listen, we found a small defect, I cleaned it for you, let's see how you do, and maybe that alone will be effective. And there's a number of data on that shows it's effective. If it's not effective and it's a fairly large defect, and by large I mean imagine about 2 by 2 centimeters, about the size of a quarter, and they're still having pain, we may consider a treatment. The 2 main gold standard treatments are MACI, M-A-C-I, or a cartilage transplant. If they're a candidate for MACI, tend to be more on the kneecap or the trochlea or the groove. And if we do a transplant, that tends to be more on the condyles. Again, these can be used interchangeably, but this is sort of the options that I have. There's more information available on my website, but at least this is the breakdown of the different options that we have. And these are effective, but again, people have to understand, cartilage is difficult. There's a reason that there's a few people that specialize in it. It's challenging, and you have to be all in if you want to take care of these problems. And success rates are high, but they're not 100%. So we're looking at many of these procedures being in the mid to high 80%. That being said, I'll tell you, many of my patients still choose this option because a lot of them are told there's nothing that can be done for their knee, and they're in pain, and they're in their early 30s to early 20s.